For those of you who don't know me, I'm the Medicine Service Chief at the Seattle VA, Rudy Rodriguez. On behalf of the Committee on Minority Faculty Affairs and the Center on for Health Equity, Diversity, and Inclusion, and the Diversity Committee for the Department of Medicine, it's my pleasure to introduce Dr. Eliseo Perez-Stable, who in September of 2015 became the director for the National Institute for Minority Health and Health Disparities. Eliseo was actually born in Cuba and grew up in Miami. He did his undergrad at the University of Miami and medical school there also before coming to UCSF. At UCSF, he had a 30-plus year career where he did his internship, residency, fellowship in general internal medicine, became the division head for general internal medicine, also the director for the Center on Aging for Diverse Populations, and the director for the Medical Effectiveness Research Center on Diverse Populations. His research career is incredible. His research is focused on improving health outcomes in minority populations and vulnerable populations, along with improving communication among physicians. He's recognized as an expert in Latino health, especially in tobacco cessation, tobacco policy in the United States and in Latin America. So we're lucky to have him here today. On a personal note, I've known him for over 25 years. And he was a mentor and an advocate of mine at UCSF, and there are probably hundreds of faculty and house staff that could say the same during his career at UCSF. We also did a lot of work together on increasing diversity at UCSF at the School of Medicine and Department of Medicine. So it's great that one of the good guys became head of an NIH institute. So help me in welcoming Dr. Eliseo Perez-Stable.
Thank you. So good morning, and thanks, Rudy, for that introduction, and thanks to all my old friends and colleagues from the University of Washington. I think having spent 37 years at UC San Francisco, University of Washington certainly as a sister institution that we always had connections with, and it's always fun to come up here. But I'm in government now, so it's a different life, and I have to just share sort of from a personal perspective. You know, people say, well, why did you do this? Were you unhappy at UCSF? I wasn't. I didn't go looking for a job. I just said, let's see what happens. And I think the opportunity to have influence, impact on a national level sort of drew me to NIH. I had gotten to know the NIH a little bit better as a council member on NIA and saw how it worked. And as a PI, as an investigator, I never really connected to NIH very much and talked to program officers, review committees. But being on the council for 4 years in a very well-rounded and highly functional institute such as NIA, I think it helped me attract me to this position. Sort of the obligatory disclosures really have no financial relationships now. My objectives today is really to talk a little bit about NIMHD, just a bird's eye view of what we're about, being the newest institute at NIH. To talk about mechanisms of disparities and how we can promote or impair the development of health disparities in different settings, and then share some of the interventions, approaches that could potentially decrease disparities, particularly in the population as well as in healthcare settings. Briefly, our history goes back to 1990 when Dr. Louis Sullivan, as Secretary of Health and Human Services, established the Office of Minority Programs. This followed on the heels of the Heckler Report that was published in 1986. It was the first time the United States looked at systematically at the health of Americans by race. It was elevated to, or changed the title to Office of Minority Health Research in 1993, and in 2000 transitioned to become a center. And as a center, you can give grants, such as we see now with complementary medicine. That was done through legislation. And again, in 2010, through the ACA, NIMHD was elevated to an institute. So the immediate question is, well, what happens now? The answer is that we get appropriations as an institute, and there's no necessary change in that status, independent of the rest of the process, which is, we all know now, is very complicated. Our mission is really to focus on minority health and health disparities research. And I think the first important task is to have ourselves be established as a credible, robust scientific area. A lot of times I think at the NIH people say, well, is this all political or is it all social? So what is it about the science? And I think we're at that stage now of establishing and connecting on this credibility and contribution. And the field has moved quite a bit since 1990 and clearly even since 2010. We're also mandated by Congress to actually generate a strategic plan for the agency on minority health and health disparities. One is on the website, it's from 2013, and it antedates that. It's not very readable in terms of length and the way it's compiled. And so one of our tasks this year is actually to really work on that after the initial groundwork that we did last year, although we won't have any updates on that for a little bit. But I expect by this time next year that we'll have a fairly advanced on that role. So what is minority health? And we operationalize this as minority health research on anything that relates to specific minority groups in the US, whether the outcomes are good or not. Whether the comparisons within or across groups or to whites or whatever. This is minority health. And we propose and assume that any race ethnic minority group in the US does share some social disadvantage and are subject to discrimination in our society historically, with various degrees. Clearly, American Indians and African Americans have had more extreme exposure of discrimination, but this is something all groups have shared. Most of you or all of you should be familiar with the classification from the Office of Management and Budget. There are proposals to changes for 2020, but our minority groups and our mandate are listed here. African American, Asian, American Indian or Alaska Native, Native Hawaiian or other Pacific Islander, who are actually different from Asian, although most of the time you'll see them lumped together, and Latino or Hispanics as the only ethnicity recognized. For 2020, they are proposing changing this back to one question, race or ethnicity, and adding another ethnic group, which is Middle Eastern North African. I don't know where this, they asked for public comment, but I don't know what the status of that is yet. That was a year ago, or yes, in late 2016 that they asked. Health disparity, on the other hand, is a population that we identify as having some systematic set of health disadvantages and outcomes. We include all racial ethnic minorities. We include persons of any race who have less privileged socioeconomic status, so poor people. Rural residency is in our mandate. This was a political process maybe 10 years ago, now clearly becoming more relevant for a variety of reasons. And last October, we, after a long process, declared that sexual gender minorities were also a disparity population that we were targeting for research. This is for research. No other aspects in health and human services is affected by this. We then take these disparity populations and look at health outcomes that are worse, and that's a health disparity. And we believe that the way these health outcomes are worse could be often attributed to social disadvantage, being subject to discrimination, and being underserved, although there are other plausible pathways that need to be examined as well. And this is what the research is about, so we focus on this population, we look at advancing knowledge and defining mechanisms on these health determinants affect disparities. We all want to know how to make things better, so everyone's eager to do interventions. Everyone wants an intervention that works. And what I would just caution us to be sure that we have some evidence that we understand the mechanism and have a plausible intervention before it gets launched and invested in interventions. We don't need to allocate resources for interventions that end up as negative studies. I tried to get our staff to generate sort of outcomes that we could compare across populations, and these are our current list. So incidence or prevalence is a given. Some premature or excessive mortality is also the two most common things that people look at. And then I like the concept of having a global measure of burden of disease, and DALY's is listed as an example. There are several others. The science on this has advanced quite a bit, and it allows us to compare things like chronic back pain to heart attacks. And then the final one is intended to be sort of standardized measures of patient or person function and quality of life. So anything and anything that is a measure that's been standardized, validated, and found to be reliable, psychometrically sound, or observation-wise, so activities of daily living in older adults, depressive symptoms, rheumatological symptoms, quality of life measures, health-related quality of life measures that have been used over the years, etc. And I think these are important outcomes that we know media is. After all, we're in this business not just to make people live longer, but to make them feel better. And this is important. We've developed this framework, which will very soon be on our website, inspired in part by some work that we did at NIA with Carl Hill and Marie Bernard. And we published a framework of health disparities, minority health, and aging. And there's no intent here to capture causality, but just to create a landscape of where this research is. And it helps, I think, scientists who are not doing this to understand what we are about, so that we do count about individual issues that are biological, behavioral, physical environment, social, cultural environment. Not only has biology exploded in information over the last 20 years with the Human Genome Project, et cetera, and the stuff that is going on now is, I think, fairly amazing for a total non-basic scientist, but also the physical environment literature took off in the late 1990s, and understanding the importance of place and where one lives and how that affects your health, I think is a critical component. I also like to introduce the importance of the healthcare system. NIH has not focused on clinical research very much. They all do it, but they don't talk about it too much. They sort of say, well, that's not what we do. They do clinical trials. The NCI has everything, so they do have a big component. NHLBI now has an implementation science branch that they're very active in. But I think that focusing specifically on what's going on between patient and clinician, both in the communication, on the big picture, in services, over-prescribing or under-prescribing or testing, I think these are all important areas for minority health and health disparities, independent of everything else that one may consider. So let me pivot to a more content area of topics, and I want to start with clinician-patient communication. And in a summary, sort of outline why I think this is a powerful laboratory, both to do research and a powerful intervention that we individually all have when we see patients that probably has been underemphasized and underutilized. So this is directly linked to patient satisfaction, better adherence, and better health outcomes. It's an intervention that works if you have effective, good communication. And it's not something that we necessarily have valued up and down the system as much as we should. I think it has gotten more traction in the last decade, but it still have a ways to go. Commonwealth survey asked, this is dated from 2001, Commonwealth survey asked whether patients had trouble understanding their doctor, whether the physician did not listen or had questions they could not ask. So these are common outcomes. And now you could add the one, did he look at you or she look at you at all during the visit? And 20%, almost 20% of patients had one or more yes responses to these three items. And that just seems a kind of high number. And it varied by race. You can see that it was lowest for whites, higher for African Americans, and then highest for Latinos and Asians, where language barriers or cultural barriers may play a factor. Lisa Cooper at Hopkins did this study also many years ago in early 2000s, where she did race concordant visits and patient-centered communication by doing qualitative analysis of audio tape measures of patient-centeredness. And this is a great example of rigorous research using soft outcomes and qualitative methods. And she was interested in how much was the interaction patient-centeredness, how did the patient rate the physician's participatory decision-making style, one of the common outcomes or items used in evaluating patient-clinician interactions. So it's all perceived by the patient. Race concordant visits, first of all, were longer. They were 2.15 minutes longer. Now, for a layperson, that may say, what is that, 2 minutes? But for any of you who are in practice or who see patients in an outpatient setting, that's not an insignificant amount of time, particularly when you have all the documentation to follow. And the patients had a higher positive affect. Patients were generally more satisfied and rated physicians higher on being more participatory when there was race concordance. So this is evidence that we probably ought to have more workforce diversity. In the medical school graduates in 2014, 5% were Latino, 6% were African American, and American Indians were barely registering. Asians are overrepresented as a global group, so that's not, it's somewhere around 15 or 16%. So there is evidence, empirical evidence, besides Lisa's study and other studies like that, that actually having a more diverse clinical workforce is good for patients' health. And so I think we have an urgent mandate as a profession to address this in the clinical world. I talk about research in a minute. We have data that published in the New England Journal of Medicine twice that underrepresented minority physicians are more likely to see uninsured patients, Medicaid patients, and they have, in a study that I was involved with, one of our former UCSF students, of graduating seniors from the AAMC survey, greater intent to work in underserved areas. This is in press in academic medicine. Even though they carry a loan burden that is at least double that of non-minority students. So their average loan burden is $200,000 graduating from medical school. They're more likely to, they have a greater intent to work in underserved areas. Now, intent does not mean behavior, but there is usually a pathway, a causal pathway that's supported by other research. Now, on the science side, we're dealing with an even bigger problem. Only 5 or maybe 7% of all NIH R01 grants, sort of the gold standard currency at NIH Science, are awarded to African American and Latino principal investigators. 5 to 7%. Now, the last time I checked, that's about 30% of the population. So there's a big gap. And there is a sort of an urgency to do something about it. There is data from Donna Ginter's paper in Science a few years ago that there's some bias in the funding for African Americans. Those data have been reanalyzed, more complete than what Dr. Ginter published, and the bias is still there. And one of the potential lesions is less resubmission of scored but unfunded grants by African American PIs. We think mentoring, networking on a national level is a factor, although there's no data, this is speculation. And the other proposal is that minority principal investigators are more likely to submit in low success topics. And of course, what are low success topics? Include minority health, health disparities. It actually also includes kidney disease, hypertension, things that are disproportionately affecting these groups. Hannah Valentine was recruited to NIH to be the Chief Diversity Officer, and there are a number of interventions as well as experiments going on now to look at review bias, to look at ways to increase resubmission for first-time R01 submissions that don't get funded, that are scored, because just a resubmission, fixing and resubmitting doubles or triples your chances of getting funding on average, of course. This doesn't mean you're automatically gonna get it. Now, looking at a population side, we see data like this coming from the U.S. Census. What does income, and if we're able to have a better measure of wealth from these data, there are measures of wealth, but they're not as generalizable as what these are converted from the census. If you're under poverty, you have 3 times chances of dying compared to if you make over $115,000. And people over $115,000 may include the 1,000 billionaires and the many millionaires, but most of those people are not exactly wealthy. They're professionals or they're in well-paying jobs, administrative, or they're successful business people. And you see this gradient. Now it kind of flattens around 80,000, begins to go down, and so you can, but it is a direct relationship to mortality, to all-cause mortality. Now, this is compelling evidence that this is something and we're not going to fix this. We live in a society that will always have some generation of inequality because of our economic system, and we accept that because it's the one that works the best, and we need to then address these inequalities when they happen, and really focus on this. Now, life expectancy data have gotten some press lately in the last couple of years in the medical literature. I don't think these are published yet. This is from the census presentation I attended, Elizabeth Arias, and you can see where the U.S. is in 2014. Notable here is that Latinos have the longest life expectancy, both for men and women, and this is now been consistent now for over 10 years that the CDC and the National Center for Health Statistics have released these data. They sat on it for probably at least a decade before 2006, worried about are they accurate, are they valid? When Asian data are available, I'm told it will be soon. I suspect maybe the life expectancy for Asian women will win out as the longest. For African Americans, we know it's lower, but there has been remarkable progress in the United States over the last 30 years. And the progress was accelerated in the past 15 years. So the same story we heard about, white mortality went down, life expectancy went down. The black life expectancy got prolonged, exceeded the expectations of demographic projections. Latinos are off the chart because they look like Germany in life expectancy. But for whites, the story is that it was all social class. The reason whites' life expectancy went down or flattened, initially noted in women about 10 years ago and then subsequently in men, is all about poor people and not related to a global effect of all whites. Now, the Chedi paper, Dr. Chedi and his group and the group of economists that published this in JAMA last year, a very important and clever way to approach this, looking at tax records and then the Social Security death registry. And the bottom line was, the richest versus the poorest. So the top 1% of the U.S. on average live 10 years longer than the poorest 1%. Now, that's an extreme comparison to make a point. And for men, the difference is 14.6 years. They did the analysis to show that the inequality has either been stable or flattened or actually gotten worse. But the message I got from this study that to me raises the biggest question is why the bottom quintile in certain areas, urban areas, live 4 to 4.5 years longer than other areas. So this is the same SES strata, bottom quintile. And to give you examples of areas, so often people say, well, it's urban-rural. Yes, some of it was urban-rural, but it was actually things like Detroit versus Birmingham. And yes, Manhattan and San Francisco actually were much better than the worst areas. So what is it about those communities taking care of their most vulnerable that they're actually doing palpably better? So I think, and the analysis they did said it was all behavioral difference. Without getting into details, I don't buy that. I think that there's some unknown factors related to place, infrastructure, commitment that is not coming through in this big data analysis. Two other studies that were published in January by MMWR, I think worth noting. The rural residence is a health disparity confirmed by this National Vital Statistics comparing mortality for leading causes of death by urban-rural categories. Heart disease, cancer, COPD, accidents, and stroke were looked at. Mortality was higher by rural residents compared to metropolitan areas for all 5 of them. And you can look at the reference from January 13th in MMWR. Investigators at NIH on the intramural program, actually from NCI, published this in Lancet later in January, looking at death certificates, so the limitation of that method from National Center for Health Statistics and census data, and then creating age period cohorts over this course of these 15 years. And because it was premature mortality, anyone 65 or over is, okay, you've lived your expectation, right? But we know that's not true, but they did it for analytical purposes. And looked and showed that for whites, as already had been published, the premature mortality was actually increased. And it was also, they were able to publish data for American Indian Alaska Native. And the causes were accidental, mostly overdose, medication, opioid, chronic liver disease and cirrhosis, and suicide. So substance use and mental health being the 2 things that sort of strike out as the increase, this flattening of the life expectancy or decrease and the increase in premature mortality. The worst group were women, white women at age 30, increased to 2.3%. American Indians women also increased on an annual increase of 4.3%. This is the highest level, so it wasn't clear all age cohorts were not the same. The flip side of this, there were marked improvement in decreases among Latinos, Blacks, and Asian Pacific Islanders, with up to a 3.2% decrease for Latinos, 3.9% for Blacks, and 2.6% for Asian Pacific Islanders. This is annual decreases. And the decline in these groups was from improvements in HIV, cancer, and heart disease. So the first and second leading causes of death and disability, and of course the remarkable progress we've made in managing HIV. On absolute numbers, American Indian and Alaska Natives had the highest mortality of any race ethnic groups, and Blacks were still the second highest. So even though we're seeing progress, and I re-emphasize this because we're always talking about things that are worse, and I think that there has been palpable improvement in public health and in population health, remarkably really over the last 30 years, and accelerated in the last 15 years. And so this is something just to keep check on as we go forward. Now, thinking about the healthcare setting, what can we do to make outcomes better? And I'll go through this, these sort of major categories. First, and perhaps most important initially, was we expand access. And sort of the public health paradigm was, if you get access, we'll make things better. And we've lived through an experiment the last 3 years where we did expand access by a significant amount. Now we need to monitor and see what happens, both from a access perspective of the health of those individuals. We know these things take time. And Oregon actually has had some experience in this, Massachusetts as well, and there have been some analyses that are regional. Health insurance is one step, but we also need a place and we need a clinician. I mean, these are fundamental factors in access. Second area is public health consensus. We don't need more data. We just have to go out and do it. And there are some times when we don't even have the data, but we just know it works. And I'll show you an example of that. And then getting into more nitty-gritty, the whole area of coordination of care, systems, navigators, target conditions. As a general internist, although it's been 1.5 years since I was active as a clinician, one of the things that was remarkable for me is how over time patients got more complicated, the chronic disease burden increased, yet they all were still there and going and getting older. And being at UCSF, of course, you know, at one point it was all the heart disease and heart failure, and then it became the chronic kidney disease, and all these patients were not getting to dialysis yet because we had ways to prevent that. And then the last few years, I was taking care of a dozen or so transplanted patients because I was at UCSF, of course, and their doctor wanted me to see their kidney, mostly kidney transplant patients who now have a new chronic disease. They're on immunosuppressants. So I think this coordination, case managers, high utilizers, this is an important area that we need to research. Patient-centered home, which in my view, in a simple perspective, is good primary care with information systems that work, and then added staff in the group. And there is some indication that it could enhance effective communication with cultural competence, and so this is a promising component. And then performance measurement. And by this, it could go all the way from just generate data on how you're doing on the metrics that we think work, like hemoglobin A1C under 8% for diabetics, or blood pressure control under 140 or 150, depending on the status of the data at that time, et cetera. They can also look at cases of quality. And then do you just feed back the information to the doctors? Doctors and clinicians would say, okay, I want to do better, and here's my average. Or do you actually put money on the table as an incentive? And this is where this is going, and you put at risk. There is a risk that the most vulnerable will get left out. And I think CMS is aware of this. How we address this, there's been some commentaries in the medical literature recently on this. But you could easily look better if you get rid of the patients who will do worse. And people may assume, well, if you're minority, you'll do worse. If you don't speak English, you'll do worse. And if you're poor, you'll do worse. So we won't take care of those. And many of our settings don't exclude patients on those criteria. At UCSF, we didn't, except perhaps in University Hospital by insurance, but there were plenty of Medicaid patients there. But a lot of practices don't do that, and they will be more selective. So I think this is an important area, especially as we see some more changes in the system. So some quick data. Infant mortality. U.S. always gets beat up by not doing as well as other high-income countries. And we can see that over the last decade, there's been significant progress, particularly If you notice among blacks, where the decrease is still very high, and this is actually a vexing health disparity, minority health problem that still needs a lot more research. Why does this persist? What's going on? And you see Puerto Ricans have really also decreased significantly. They also had an excess number. I'm from Cuba, as Rudy mentioned. The Cuban-American rate is actually lower than the Cuban rate, the rate in Cuba, although they're both extremely low. And Cuba infant mortality may actually be just a tad lower than the overall US one. This is childhood immunizations, not counting hepatitis B in this case, but I think if you include B, you get these same numbers. We're over 90% for everybody. So, and this is a mandate. This is a public health priority, and we've done it. Now, keep in mind, there are groups who don't believe in immunizations and are actively against it. It's predominantly an issue of more upper middle class whites. I don't think this has been studied, but I don't hear that this is a concern of most minority groups. But this may also become a more sensitive issue in the near future. Hypertension, prevalent, disproportionately affects African Americans, maybe not other minority groups, but they're not any lower. We know the numbers about who gets treated and who gets controlled. We're much better than when I was in medical school, but we're still a little over 50% are under control. We know that this is from NIMHD, that if you're Latino, black, or young, or very old, poor, or have less than a college degree, you have higher rates of uncontrolled hypertension. This is from big population data. And we know that if you have insurance, go see a clinician twice a year and have some usual source of care, can identify a source of care, you have better control. So it's indirect evidence that primary care actually, or having access is good for your health. This is from the REGARD study published a few years ago. This is a large cohort study of looking at stroke. And just highlight one bullet here, this. So for systolic blood pressure increases in what would be of 10 millimeters of mercury, the stroke risk went up by 8% in whites and 24% in blacks. Adjusting for other factors, the hazard ratio was 2.38 for stage 1 hypertension. So this is systolic under 160, diastolic under 100, or 104. In people that are in midlife, where we actually know from a lot of other data, or from some other data, this is where the major health disparities are generated. This is where you see the biggest gap in outcomes. If an African-American man or woman makes it to 65, they actually have almost the same life expectancy, and in some analyses, longer life expectancy than their white counterparts. So we know this, that hypertension is not an equal opportunity risk. And have we acted on this yet? I mean, this is one of some of the issues I brought up with the task force in a recent phone meeting, and I think there is something in press in the Annals of Internal Medicine trying to look at this, but we haven't really systematically addressed this in a more, in a clinically important way. If your hazard risk is over double, for the same level of blood pressure, shouldn't we be more aggressive in managing blood pressure in that population? Well, the opposite happens. We see from NIMHD data, if you're non-Hispanic white, 56% are controlled, and if you are Asian, Hispanic, or non-Hispanic black, the numbers are all considerably lower for both men and women. And so this is related to other factors, not because doctors or clinicians don't want to treat their patients. Yet Kaiser, perhaps like other large health maintenance organizations, as you have here, showed us how to do this. So I say, well, we got to do it. We can't sit around anymore and say, oh yeah, this is interesting. So they did and this is using drugs that some people would consider old-fashioned, thiazide and ACE. The treatment guideline get the goal, so they have a registry, they identify their patients, they use NCQA metrics, so they're comparing to other California groups, and they went from 43% to 80% controlled over a course of less than 10 years. In comparison to the other groups where there was improvement but not as marked. Besides the registry and creating performance metrics, creating guidelines, having combination drugs on their formularies so it would be easy and cheap for patients to get a thiazide-ACE combination as a 1 pill a day. They had open access to medical assistant visits so the patients could come in, get their blood pressure checked, and there was a protocol the MAs could follow and say, okay, we adjust it this way or that way, or they would call the doctor the clinician and say, so-and-so's here, their blood pressure is 170 over 100, what do we do? If it was something that was out of standard. So I think that this kind of a program should be adapted and implemented in all our practices to get our blood pressure control on our patients to 80% or better. 80% is sort of a ceiling, and you then pushing it higher will take more resources probably. And no longer sort of, oh, you're not adherent. Oh, we didn't get the right drugs. Oh, they couldn't. You know, so we have to really make this a priority, and I think the evidence is in, we should just do it. Cholesterol is a little bit different. We don't see as much of a gap. This is high cholesterol. This tracks with, this is also from NHANES and published in Circulation. Treatment is higher for whites. Interestingly, not as much of a gradient for SES as education, but you do see a controlled difference here. So maybe adherence is playing more of a role here, or affordability of the medications. Mexican Americans consistently have the lowest level of control of LDL, although their absolute rates are not as high as whites, but they're less likely to be treated. And if we look at cholesterol, I mean, this is work from John Ayanian published a couple years ago, and what happened between 2006 and 2011 as these data became available. And I want to just emphasize how good the West did. So the difference, the gap between blacks and whites was obliterated in the West. And this is probably, I mean, the causal factor here is the large health maintenance organization. So Kaiser in California and Oregon and Group Health here and whatever other organization, however that organizational culture has spread to other medical groups. We don't see the gap disappearing in these other areas at all. There's slight improvement, but not as much. Again, I think good evidence to say, well, this kind of approach, using population health as an approach, we have the evidence now that we can work with the indicators. And what this said was that similar results were found for blood pressure and blood sugar control in this same data set. Now, let me change to show you some data about cancer, where the factors that lead to differences by race, ethnicity are probably a little bit more complicated. When we first looked at them, these are not necessarily the most up-to-date numbers, but they're close and the relationships are the same. We look at cancer rates by race, ethnicity, this simple variable of saying, what's your race? And even lumping Asians and Pacific Islanders together and using Latino for as an, we see these unbelievable differences. So look at prostate cancer. African American men have a rate of prostate cancer that is, triple, almost triple that of Asians and double of whites and Latinos. So what's going on there? Everyone's, oh, it's genetic. Oh, maybe. There is definitely some alleles that have been identified that increase risk of getting prostate cancer and severity. It's probably not the only answer. And I think this is one of these challenges where we can't really understand this or solve it by one discipline. This is not epidemiology, this is not behavior. This has got to be a combination of all the disciplines to say, well, how is this problem be attacked? Similarly, lung cancer, something I have had more interest in. Why do African American men have more lung cancer? We know that tobacco smoking is about 85 to 90% of the attributable risk of lung cancer. It causes lung cancer. Yet we know also that blacks haven't really smoked at a rate that is not much higher than whites. We do know Latinos smoke at a lower intensity, and Asians are heterogeneous in that. But we can see this rate exceeds that of whites or Latinos. And there's other data I won't show today that confirms this based on even intensity of smoke and so forth. So liver cancer, we actually published a funding opportunity announcement with NCI and NIAAA on chronic liver disease and liver cancer, looking at health disparities and minority health in those contexts, the whole spectrum from translational work to clinical work, because one is that common is actually disproportionately affects men, and the etiology, the reason why people get liver cancer varies. So it's not just hepatitis B and C, it's maybe fat, there may be other factors, obviously cirrhosis from any cause, including excess alcohol use. So I think this is an area that we want to promote some active research in. Now, turning to women, we see similar incredible differences, and these are not subtle differences. When you have a difference of breast cancer in African American and white women that is, 20, 25, 30% lower among Latino women, there's something going on. Now, there was a gene identified among Latino women that is present only in women with American indigenous background that is protective of breast cancer by a reduction of about 40%. Laura Feherman published that in Nature Communications a couple of years ago. I was part of that work. And that's one potential partial explanation for what we see here. And then we know at cervical cancer, of which we allocate a tremendous amount of effort on, is more common in minority groups related to HPV, although not exclusively, and we can see that it is relatively low in terms of incidence in the US. A couple other quick snapshots of population health. This is prevalence of colorectal cancer screening. This is a little bit dated. We have room to go, but you see this ethnic race gradient, lowest for Latinos, probably related to lack of insurance at that time, highest for whites. And this is any screening, so either fecal occult blood test or colonoscopy, sigmoidoscopy. And you see this remarkable gradient by SES measured almost exclusively by education, since that seems to be the simplest way for a public health survey to publish this. In fact, it's even more important. John Inadomi, who's here, published this paper, which I really liked when it came out, because it illustrated two things. First, it heightened the importance of not focusing exclusively on colonoscopy, and as a gastroenterologist, he gets special extra credit for having published that. But that if you actually use a simpler approach of saying, well, do fecal occult blood testing with the FIT cards even better, easier now, you not only get a higher number of people get the test, but you actually present it as a choice. So African Americans and particularly Latinos and Asians were more likely to get screened at all after 12 months if they got offered the FOBT. Colonoscopy as the only offer, you saw that African Americans and Asians were less likely to get it. So they just didn't want that idea of somebody putting a hose into their rectum, right? And there's just some people, as a primary care doctor, I talked to hundreds of patients over the years about this, and there were some people who just, don't touch me. Other people said, don't want it. Other people said, give me the appointment. And then when you give a choice, you again see that the colonoscopy rates were generally lower for all groups. So I think an illustration of strategy and also how race, ethnicity can influence that. And just to re-emphasize why this is an important variable to measure and to take into account when you're doing clinical research. And in a diverse setting like San Francisco General Hospital, it's inevitable. But I would argue that for any setting, we ought to do this, and the same would be true for other social determinants, particularly socioeconomic status. Breast cancer screening, to some degree, this is old data, but we're close to 80% for almost all groups, with limitations of the data for small populations like American Indians. We see this gradient by SES, so you could argue, well, mammography, we have to now sustain it at some level. So what's happened from the same Medicare analysis approach that John Ianian used, we can see that for blacks and Latinos in Medicare HMOs, they actually are better than whites. So guess what? This approach to population health seems to work pretty well. And the same is true for Asian Pacific Islanders. While traditional Medicare, we see a gap for all three groups. And just something as simple as ordering a mammogram and getting a woman to get a mammogram every 2 years. Now, not without getting into that discussion. Back to patient-doctor communication, I want to just dwell on something that we were involved in a series of studies that we did when I was a few years ago at UCSF. So there is this assumption that shared decision-making is a gold standard, and I don't push back on that, particularly when there are clear-cut different approaches to therapy. I would say, though, that for common things, it may need reevaluation. So if let's say you do shared decision-making for a screening test, are we going to present a risk in absolute numerical scale, so real risk? So what's the real risk of getting invasive colon cancer at a 50-year-old? Your lifetime risk of getting colon cancer on average in a population is about 10%. And if dying from that, maybe 5%. Now, if you get a colonoscopy twice or fecal occult blood test 10 times, you reduce that by, at best, a third in the best study. So you tell a patient, well, you go from 5% to 3%. And the patient says, what? Right? So, the epidemiologist patient will understand, but I don't think anybody else really does. So I think we really, and even doctors, clinicians, have problems with odds and percentages. It's not perhaps as common as the numeracy would be in the general population. So absolute risk reduction, which is really what we ought to focus on, not this relative risk reduction, which is sort of fool's gold, in my view, in clinical research, is modest at best, but yet we have a public health consensus. There's the compelling clinical trials that show you this works for the population, so we should just recommend it. And then part B would be, well, for the patient who really needs a lot more information, especially data, you can shift to the numbers. How are we doing on time? Okay, so let me quickly skip over the limited English proficiency work. It's important. I realize that here in UW, there's actually been some of the initial work on this was done. These are some of the outlines. I won't go over them all. I'll just show you quickly data from Kaiser that Eliseo Fernandez published a number of years ago, showed that discordant patients actually had a higher odds of having an A1C over 9%. Just a couple months ago, that group published more analysis of this diabetes study showing that that language concordant patients had improved A1Cs, and then when they transferred to a non-concordant provider, they still maintain their A1C under good control. It's a good system that does a lot of things, and so perhaps initiating with a language concordant clinician is important. Readmissions to the hospital, this is from a single institution in Boston. This is pretty amazing. So you get an LEP patient in, no interpreter ever used during the hospitalization. No interpreter. So I guess it's veterinary medicine. So 24% of the time, patient gets readmitted. That's high. We want to say, we think 15 is the floor, maybe a little bit less if we, but interpreter, even used as the discharge or admission, you get no difference. And of course, using both is a little bit better. So, this is a matter of quality. We did a study on errors, a qualitative study in the Bay Area at two different clinical settings. These are diverse settings. It was not randomly selected. It was sort of certain days of the week. Faculty, residents, and PA, nurse practitioners, interpreter was present. And we tried to categorize frequency and category of errors using a unit of analysis called text units, which is a phrase in the audio tape transcribed interaction. There was on average 27 errors per visit. Most of the errors had some level of clinical significance, but most of these 60% were of low level and not anything you as a physician or a clinician would be concerned about. But there were clinically significant errors, and they occurred 7.2% of all text units. And the two examples we used in the paper was one interpreter told the patient to take an acetaminophen dose for pain that, if combined with a little alcohol, would lead to liver toxicity. It was like 8 grams a day of acetaminophen based on the instructions, so they were clearly incorrect. And the other one was misinterpreting chest discomfort, chest pain, as shortness of breath, and steered the physician or the clinician to evaluate this not as what it should have been evaluated as an ischemic equivalent or cardiac, and needing a cardiac evaluation. So we feel very strongly that this is a policy and a quality issue, that we need professional interpreters present in the room. You could do it in person, or the technology now with video teleconferencing is so good. And we implemented that in our general medicine practice at UCSF. You get high quality image. It's stable. In the hospital, the stability of the EMI was not as good, but certainly there are other ways to do it in the hospital. So use it whenever possible. It's about quality. Health systems really need to increase access to language services. It's one of those great unfunded mandates, but now we have empirical evidence that this really makes a difference in the quality of care. And in the inpatient, what Leo Carliner found was that dual head telephone is really quite a good intervention, with access to then language services that do the interpreters at the spot. So it got nurses and doctors to talk to patients in the hospital, because you're doing rounds, you're doing like 3 minutes in a visit, and before, when you didn't speak the language, you sort of say, it's like, you just observe and say hi, and that's it. Now the patient says, phone, get the phone, and then And then you have the 3-minute conversation that you have with everyone else as an attending or the nurses. So I think this is really something that the time is now to implement this, and I think it will help improve quality and also outcomes that matter to everyone, including the CEO of our hospitals and health systems. I also think that clinicians who are bilingual need to be tested and certified as bilingual, so that they are now empowered to see patients. And there had to be some recognition, some compensation, because they're saving the system an interpreter, as long as the system has committed to an interpreter. And so in that regards, some recognition is valuable in that case. I even think that the bar will go even higher, because one of the things I learned in UCSF when we went to the electronic medical record is that I was writing messages to patients in Spanish. So it wasn't just verbal fluency, but that people also potentially will then need a second level of fluency with a written language. Smoking cessation is an area I have done a lot of work in. I'll just mention that the paradigm of smoking has changed in this country. Half of all minorities who smoke are light or intermittent smokers. The addiction paradigm does not fit for those people, for the most part. And there really have been, as far as I know, 0 randomized clinical trials of smoking cessation with non-daily smokers ever done that I know of. We haven't found that doctors, clinicians treat minority patients who smoke differently, and we need to think about what interventions we're going to do in this. We have made public health progress. This is from CDC a number of years ago. So detectable cotinine in the population. So this is a very sensitive measure for secondhand smoke. We can see it's gone considerably down in all groups. Still highest for people below poverty, still highest for African Americans, but it is lower across the board. Now, does 0.05 nanograms of milliliter in the urine or in blood of cotinine harmful to you? I don't know, but there's 150 carcinogens in tobacco smoke, in secondhand tobacco smoke, so it's not the nicotine, it's the other stuff that we're worried about. Food and housing security, other social determinants, very recently published by the CDC, and again, something that as a clinician, we ought to begin to think, well, how do we get at this with our patients? It's more common among minorities. Housing security is highest among whites, and so is food security, and there is, again, an SES gradient by education. I may want to stop and because you go till 9, right? So I have too much other stuff that I didn't cover, so let me just go to the end here and skip the diabetes, sorry. Dr. Bremer. 3 points to make to finish. So we need standardized measures. We got to do the basic things right. And in our health systems, we ought to collect in our data standardized ways of getting a demographic and social determinants. Whether it be race, ethnicity, well, that's for sure. Some measure of social class, such as years of education, are not that difficult. There are a lot of other things I'd love to see, like country of origin, immigration, etc., and then go on to get metrics of health literacy, numeracy, food security, which matter. And then I don't know how to measure neighborhood yet. I don't know if anybody really does. People use zip code, and yes, but zip code's kind of a big variable. And it means different things in urban settings and in suburban settings, and etc., or more segregated urban settings. So I think this is areas that are needing help. Health IT is, we're in the midst of this first phase of adapting it to the medical record. Every doctor I've ever talked to hates it. The patients are mixed, but most of them like it, that have access to the higher end IT. They like the fact doctors have all the information in front of them. And how do we adapt this so that there isn't a worsening of disparities? So facilitating access to older adults, touch screen technology overcomes a lot of the barriers. What about limited health literacy, limited English proficiency, etc.? And then having proxies be empowered to communicate. So some of my very elderly patients at UCSF would not go on the portal, but their son or daughter would. And so I think these are things that we ought to think about. And then thinking about visuals, whether it be video doctors or other ways to communicate with patients with limited literacy in a language other than English. And finally, precision medicine was the big thing when I got to NIH in September of 2015. I think it has tempered down. Even Dr. Collins doesn't talk about it. It's not a genetic study, as he likes to say. But it is a fabulous proposal to do this massive cohort of 1 million Americans. And it is funded, by the way, as of December by the Congress. But being more precise doesn't just mean getting the right drug or the right subgroup of this or that. That's a future thing that maybe right now we're living only with cancer treatment. But whether one approach is better than the standard one needs to be demonstrated. We really have to not forget the evidence here. Now, one size fits all actually works for some things. And I showed you the data on hypertension, and this is using old drugs and an earlier version of information systems. So we don't need to know what type of hypertension we know what to do there. And new is not always better. It's almost always, though, more expensive. So we have to take costs into consideration when we think about this. And then I like to say, well, we need precision in patient-clinician interactions, not just in drugs and treatment, and enhance cultural competence and reduce this structural discrimination that may happen in our healthcare settings independent of society. So thank you for your attention, and I'm happy to stay longer for questions.
So Eliseo, I'm over here. Am I on?
Hi, John.
Yeah, hi. This is John. So I've been interested in the differences and the impact of English proficiency versus cultural concordance, and even in my study, it's difficult to tease out. My next project, which I guess I'll submit to your institute now, is really trying to understand what are the differences. And it's different for me to speak Spanish to my patient, and very different from for my patient to speak to who actually is someone who is actually from their culture. I mean, they get it. I mean, and then the whole idea about my study about looking at colon cancer screening, you had to really understand the health belief model of that patient. And I didn't understand it. And it was just the interactions of my research coordinators with the patient that I really understood why we were able to achieve higher adherence. Was this whole culture concordance. And I'm curious where you guys are with your institute, understanding language and culture, and how important is that to you?
Well, personally, I think this is an important topic. Where we are as an institute, it depends on what you do. We fund grants. We don't do the research. I mean, we can do research intramurally, and that's a great idea of a potential topic as I build my intramural program to do in a context of laboratory with a set of cohort of patients where one can study this more deeply and not worry about having to write a grant because we allocate funds for it. But I think it's another level of question, and I agree that there probably are differences. When I was a fellow in general internal medicine, that was my project. I was going to look at the cultural factors in patient-doctor communication. I never did it. So I think we do need this kind of research. To go back to the language, though, I think there is fluency and there is fluency. And one of the challenges is that the testing for adequate fluency is really important. And it's a test that's done, with a telephone interview. And at least you have some minimal standard of you're able to do it. And the only people that were supposedly could be excluded is people who went through at least high school in their native language. So I would have to go through a test. Although I think when I first was told to do it, I said, no, I'm not going to do it. And I said, well, I should do it, so I'll do it. The written language part is a level I think most people who pass a verbal one will not pass a written one unless you're a native speaker and have actually done reading and learning or in that. Now, there are always exceptions to this, but I think these are important variables, and patients notice. Now, have there been empirical data to look at this? No, this is all based on our experience. And my wife, who's a general internist in a community clinic, speaks Spanish all the time, can see the difference in her colleagues who speak Spanish, but they're not native speakers. And so I think these subtle things is at the next level of study on this, as long as we have a significant proportion of the population that does this. When you also ask patients what they prefer in, because a lot of patients will speak enough English to get by. But if you ask them, what do you prefer to speak in, then you get at the more subtle, limited English proficient individual who would not normally say, oh, I need an interpreter. They would never say yes to that. So this is another issue. I didn't go over the data on that. So.